آه لو نشغل الفيديو يكون أفضل كمان.
طيب دكتور فارس، بس عشان نتفق على الايفنت كيف راح يكون. انا راح اقدم 5 دقائق introduction، مقدمة بسيطة، وبعدين اقدم تعريف بيك دكتور فارس، وبعد كذا نبدأ البرزنتيشن والكيسز. في النهاية نبدأ الكيو ان اي سيشنز على الساعة 10:30 تقريبا، ناخذ 15 دقيقة نجاوب على الأسئلة. and then we'll close the sessions by take home message اللي ممكن أقولها في الأخير. But this is
تمام.
how it goes. Okay?
خلاص اللي تشوفه أنا معك.
الله يعطيك العافية.
على بركة الله. على
طيب
بركة الله.
طيب بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Distinguished colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. It's my great pleasure to welcome you all here today in this educational webinar, which is very, very unique webinar because it tackles, in fact, a very important topic that encounter the primary care physician with a lot of challenges, which is a small airway disease in primary care, from early recognitions to optimizing the long-term treatment. So before I start, I just would like to set up the stage by saying, as a family physicians, all of us, we address small airway disease and as an important component of our day-to-day practice. And unfortunately, it is increasingly recognized as a major contributor to respiratory symptoms and disease progression. But unfortunately, on the other side, it's often remain underdiagnosed, misdiagnosed, undertreated, and mistreated sometimes. So as a primary care physicians, we have been uniquely positioned to be the gatekeeper, to be the first contact with patients, and we demonstrate a high quality of care and high competency of clinical competency to manage those patients by screening them, by treating them, diagnosing them, and then by referring them to the subspecialty if it's required, in fact. So it's my privilege to extend my warm, in fact, to welcome our distinguished speaker, Dr. Faris Al-Hijeli, who's associate professor and a consultant pulmonology and sleep medicine in King Abdulaziz University in Jeddah here. And he's the head of the pulmonary divisions in King Abdulaziz University in Jeddah. During today's sessions, Dr. Faris will share with us the latest update in the management of bronchial asthma and chronic obstructive airway disease through a very unique modality today. So through a series of practical real-world clinical practice scenarios, and these cases will represent a different spectrum of patients who are being encountered in the primary care setup, and he will demonstrate the evidence-based approach to diagnosis and inhaler selections, treatment optimization, and the long-term disease control. So I think it will be a very interesting session for us as a primary care physician to listen and to learn from Dr. Faris, his perspective, how to manage these cases and how we can collaborate between both of us being in the primary care and being him in the secondary care. I would like to express my sincere appreciation to JC for their generous support of this educational session and the continuous commitment to advance respiratory care through medical educations. And also I would like to extend my thanks to the FEX company for the outstanding organization and coordinations of this webinar. I also would like to mention that this webinar under the partnership with the Saudi Society for Family and Community Medicine, and we have been privileged in this society to offer you the updated evidence-based medicine clinical cases that will sharpen your skills and sharpen your knowledge in order to be competent enough to manage all the challenges that we encounter. So to all of you participants, thank you for joining us today, and we encourage you to actively participate, especially at the end of the sessions, so we'll have enough time, maybe 15 to 20 minutes to have all kind of your questions and concerns and even interactive discussion between you and the speaker. And please share your questions and experience and make the most of this valuable educational opportunity. So as a moderator, I would like to ask you to put your questions in the Q&A box. So I'll be able to select those questions that is relevant to our session today and forward it to the speaker, and we will have, inshallah, a very fruitful, highly valuable session. So without any further ado, it's my great pleasure, ladies and gentlemen, to welcome Dr. Faris Al-Hijeli to begin his presentation now. And I would like to thank you, Dr. Faris, for being with us here today and accept the invitation to be part of this wonderful scientific gathering. So the floor is yours.
طيب الله يعطيك العافية دكتور أشرف. أول شيء السلام عليكم ورحمة الله وبركاته. Thank you very much for having me. It's always a pleasure to be with you in the Society of Family Medicine. With you particularly, this is not our first rodeo, فأنا really gives me a great pleasure to be with you. And thank you for Casey and for all my colleagues who are attending in this late hour. إن شاء الله يعني تكون helpful, fruitful, we learn from each other today as much as we can. Is my screen showing to you, Dr. Ashraf?
Yes, we can see it.
Perfect.
Yeah.
Perfect. So you are the first line. You are the one who's behind the enemy line. You're always the one that we depend solo on treating and capturing patients with bronchial asthma. What I'm going to do today is to run through multiple cases. That is what we face on every day. And every day, subhanAllah, we learn from the case, from the patient, from their family member. So keep an open mind. Each patient is different, and we're trying to individualize their therapy. So this talk is sponsored by Casey, thankfully, for their participation in the continuum of the medical education. So I'll start with the most common slide. If you grasp what's in this slide, you basically are an expert in treating patients with asthma. This is the GINA latest updates or the GINA latest guidelines in treatment and management of adults patient with bronchial asthma. As you're all familiar with, there are two tracks. Track one, the preferred one, which is basically a formoterol-based track, and there is the alternative track. That doesn't mean it is wrong. It is an alternative. So you still can use it if you prefer or if the patients prefer. So there is no right or wrong. There is a preferred and alternative way. So either way you choose depends on you, your comfort, the availability of the medications at your institute, and the patient's preference. Always remember that. So I'm not going to go into the details over the step up or step down in this slide. We're going to take it from the real life cases that we're going to encounter. So without further ado, we start with the first case. This is a 28-year-old female who works as an admin officer. She has a 2 years history of intermittent dry cough and chest tightness. Predominantly work in an air-conditioned environment, similar to most of our patients that we see in day-to-day. She has symptoms 2 to 3 times per month. She has no nocturnal awakening, and she occasionally uses salbutamol inhaler. She is a non-smoker, and she has no other significant history. She is a normal body mass index of 22. So in your physical exam in the clinic, she appears well. She has no distress, normal respiratory rate and oxygen saturation in room air, normal chest exam with no wheezing, and normal percussion and no signs of accessory muscles usage. And she had mild allergic rhinitis, which is, again, more or less typical to what you see in your outpatient clinic every day. So the alert in this patient is the frequent use of the salbutamol. She uses almost 2 to 3 inhalers in 2 months. So every month she is using 1 canisters. And we're going to talk about the usage of the overusage of SAPA. She did have a spirometry. She had an FEV1 predicted of 82%. She had a normal FVC at 90%, and her ratio was normal at 78%. You know that to call it an obstructive pattern, you need an FEV1 over a FVC ratio of less than 70. However, she did have a post-bronchodilator, and the FEV1 improved to 94%. So this is basically a 12% improvement, and in the actual value, it was more than 200 ml, which confirms reversible airflow obstruction. So the learning here is if you have a normal spirometry, that does not rule out asthma. And if there is symptoms consistent, we encourage to do post-bronchodilator. If there is a significant improvement, that goes with reversible airflow obstruction based on the criteria for the FEV1 improvement. So she did have a normal X-ray, normal cardiac diaphragm and silhouette signs, and it's consistent with mild intermittent asthma. So the interpretation of the spirometry, again, as I mentioned, post-bronchodilator improvement confirms the reversible airflow obstruction, which is consistent with the diagnosis of bronchial asthma. Now, if the FEV1 over FVC is less than 70 without improvement, now we can consider thinking about diagnosis such as COPD, or very advanced asthma, or what we call remodeling. So this patient, if you want to manage this patient, you can consider it as step 1 or step 2. So if you are the track 1 preferable or the GINA track 1 preference, you will do as needed low dose ICS formoterol, which is basically a single inhaler that has both the bronchodilator and the inhaled or corticosteroid, or is the anti-inflammatory, because we all know that asthma pathophysiology is an inflammatory airway disease. So a cornerstone of the management has to almost always include an anti-inflammatory. Or you can use what we call, or they refer to in the GINA guideline as an AIR, which is the anti-inflammatory reliever. Basically, it's a single device that has both the controller and the reliever, and you can use it as needed. Now, if you wanted to use the track 2, you can use as needed SABA, but with every puff of the as needed SABA, you have to take another inhaler of inhaled corticosteroids. So this way, the patient needs to take 2 different devices simultaneously. Whenever he feels the need of taking the SABA, he has to take with it a dose of inhaled corticosteroid. Or you can elect to give the patient a daily low-dose inhaled corticosteroids, and you have to rely on the patient compliance. So 2 inhalers, and you need to rely on the patient not to overuse the SABA and ignoring completely the inhaled corticosteroids. So basically, the SABA only is no longer the preferred management options in the GINA guidelines. So it is not allowed, in another word, to have any patients, whatever is the step, that is on SABA alone. Occasional use of SABA is a red flag for undiagnosed asthma, and every ICS formoterol rescue puff delivers both the anti-inflammatory protection and the bronchodilator. So what's the evidence behind what I'm trying to tell you here? So there is the Sigma-1 trial that found almost 64% lower risk of severe exacerbation with as-needed ICS formoterol compared with as-needed SABA alone. So a significant reduction in the chance or the rate of severe exacerbation. Another evidence is the subsequent New England Journal of Medicine trial, the Novel Start, reported almost 60% relative reduction in severe exacerbation risk with as-needed budesonide formoterol versus as-needed albuterol. So this is another evidence that tells you that ICS formoterol, even as a PRN practice, showed significant reduction in the chance of exacerbations in the future. Also, Sigma-2 confirmed as-needed budesonide formoterol achieved exacerbation rates comparable to patient who is on daily ICS therapy. So even if the patient is compliant on a daily ICS, the study here found that patient who is on as-needed ICS formoterol was similar to patient who is taking regularly ICS therapy on a daily basis with good compliance. So let's move on to the second case. So this is a 42-year-old male, a construction worker. He had multiple ER visits this year for acute wheezing. He uses salbutamol 8 to 10 puffs per day, went through almost 4 inhalers in 2 months. He's been prescribed beclomethasone 200 microgram BID, but uses it only when he feels that his symptoms is bad. And he smokes around 10 cigarettes per day for the last 20 years. And as you can notice that he's a construction worker, so he has some dust exposure on his day-to-day activities. He presented a bit anxious with breathlessness, especially on speaking. He has saturation of 94%, peak flow was 52% predicted. On auscultation, he was found to have wheezing and prolonged expiratory phase and slight use of the sternocleidomastoid muscle to encourage his breathing and to improve his breathing. So the alert here is always in every single visit, quantify whenever is possible to know how much patient SABA is using and how many canisters he's using, because if the patient is using more or equal than 3 canisters, يعني 3 علب per year, this is a very significant red flag, and patient needs to be educated about the importance of not overusing the SABA and how to better control his or her asthma. Now, unfortunately, this can be challenging in the clinic sometimes because the patient will have multiple puffers, one in the office, one in his back pocket, and one in his bedside table. So they have multiple because it's cheap, accessible. So they tend to buy more than one and leave it in different places. So this patient has an FEV1 of 58%, which is significantly reduced. FVC was reduced as 72%, and the ratio was reduced as 62%. The post-bronchodilator showed an improvement of the FEV1 from 58% up to 74%. However, so this is a moderate to severe obstruction with incomplete post-bronchodilator reversibility, suggestive of either airway remodeling or chronic COPD or chronic obstructive pulmonary disease. Now, the chest X-ray showed mild hyperinflation, flattened diaphragm, peribronchial cuffing, and airway wall thickening. He had no pneumothorax consolidation and no emphysema in the CT. So as I mentioned, that you need to have an FEV1 of more than 12% improvement and 200 ml to confirm reversibility. So even if there is an improvement in the FEV1 by more than 12%, so you have to have an absolute increase of more than 200 to call it reversible airflow. Otherwise, we call it partial reversibility or an irreversible airflow obstruction. So this patient is more severe than the previous one, and he requires to be on step therapy at least. So he needs to be, if you go with a preferred approach, medium dose ICS formoterol as a maintenance. So they take it twice a day, and they take it also as needed. So instead of using SABA as PRN, they use the same inhaler, which is ICS formoterol. Why we keep saying ICS formoterol? The patient who is on SMART or MART approach, which is basically MART, maintenance, and reliever therapy. So the patient is using the regular medication daily, and they take it as needed as well to reduce the inflammation and to have a bronchodilator. Why it has to be a formoterol? Because formoterol is the only LABA that has a rapid onset of action, and it acts almost as good as the short-acting beta agonist. All other LABAs had a prolonged onset of action, so they don't have the immediate relief that the SABA is giving. So every rescue puff is also a controller, and the chance of reducing exacerbation goes up to 50% versus patient who is on a fixed dose ICS SABA or ICS LABA in addition to SABA. If you elect to go with the track 2, this is going to be a low to medium dose ICS LABA, which is a fixed combo, and SABA as needed. It requires good adherence to controller therapy, and unfortunately, despite that, it does not address the SABA overuse behavior of the patient, and they will keep reaching to their SABA. So as I mentioned, more than 3 SABA canisters per year dangerously elevate exacerbations and mortality risk. So studies have shown that mortality goes by up to 4 times in patients who are using more than 3 canisters of SABA. GINA 2024 mentioned that more than 3 is a red flag requiring air should step up, and SMART therapy converts every rescue act into a therapeutic one. So you get both the benefit of the bronchodilation and the anti-inflammatory. In this patient, there was a high risk alert where the oxygen saturation was 94%, almost daily use of SABA, poor adherence, and the need for urgent step up and smoking cessation, in addition to a written asthma action plan. Again, you will notice that with every case we discuss, we'll show you the evidence behind these recommendations. So the global SABINA cohort of almost 365,000 patients found that increasing SABA canisters collection was associated with a dose-dependent rise in exacerbation and, unfortunately, mortality. A recent systemic review in 2025 and a meta-analysis of 27 trials found that SABA overuse, defined as more than 3 canisters per year, was associated with almost 200% increase in all-cause mortality and 93% fold increase, or 93%, increase in acute exacerbation risk. Another study, the Hong Kong SABINA, were focused on Asian population, found that the highest mortality risk in patients using more than 11 per year, so basically 1 canister per month, showed an increase of 42% in the hospitalization and that goes from the 7. So once you reach to the 7 up, it increases the chance of admission to the hospital with an exacerbation. All right, so moving on to another case with a different scenario. This is a 35 young lady. She works as a teacher. She is currently on beclomethasone formoterol, 2 puffs BID, maintenance, and she is using SABA on PRN for the last 2 years. She has no symptoms for almost 8 months. So basically, this is a well-controlled patient. She has no nocturnal awakening and no activity limitations. She uses SABA only twice in the last 6 months. And we always say that if you use SABA less than twice per week over the last 4 weeks, that's considered a good control or good control of asthma, in addition to other questions, nighttime symptoms, limitation of activity, and daytime symptoms. So she asks you in the clinic if she can stop her inhalers entirely. She's non-smoker and she has no significant comorbidities. She looks well, sitting well, normal examination, without any issues. So again, when we quantify the SABA use, she was not using it that frequently. Her spirometry was beautifully normal without any evidence of obstruction and no significant reversibility. She has normal X-ray without any signs of hyperinflation. So based on the GINA, you can step this patient down from step 3 to step 2 or step 1. So you'll switch her from maintenance SMART to as needed ICS formoterol. So you tell her that you can use the ICS formoterol only as needed. So she will remain on an anti-inflammatory coverage whenever she needs with every rescue dose that she will take. So if you took the dose, she will receive both the bronchodilation and the anti-inflammation. It's very gentle, clean, simple, and you are stepping down without stopping completely the inhaled corticosteroids. On the other hand, if you elected to use the track 2, you're going to reduce the dose of the inhaled corticosteroids by the half the dose, and you're going to continue the SABA on a PRN basis. So step down means reducing ICS while again relying on the SABA for relief, which could potentially increase the risk of unprotected symptomatic episodes. So the teaching point here that any patient who has well-controlled asthma for 3 or more months, you should consider step down, not less than 3 months, but never ever stop the ICS entirely in patients with bronchial asthma, because the risk of severe exacerbation persists even in patients who have step 1, step 2, 3. So irrespective of the degree of the severity of asthma, even if they are well controlled, they still at a risk of exacerbation. And that substantially increases when you completely eliminate the inhaled corticosteroids. So again, track 1 here is an elegant as needed. So you need single inhaler, you use it as needed. If you don't need it, you're fine without using anything. So what's the evidence? GINA recommends step down once asthma has been well controlled for 3 months, but consistently advised against fully discontinuing inhaled corticosteroids, and observational cohorts of ICS discontinuation in patients judged controlled by their physicians show a meaningfully higher rate of relapse and exacerbation compared to those who were maintained on low-dose ICS or as needed ICS formoterol. So that's where the idea or the message that we do not want to eliminate inhaled corticosteroids entirely. As needed ICS formoterol preserve an anti-inflammatory coverage, even if it's an as needed basis, and it's tied to a symptoms-driven approach. And it's validated based on the SIGMA program on multiple trials. So this is the strategy that GINA is recommending for patients when we consider stepping down. Okay, so far so good, inshallah. This is a 19-year-old male who is a football player. He has cough and wheeze exclusively during or immediately after intense exercise. So basically, this is a case of exercise-induced asthma. The symptoms usually resolve 20 to 30 minutes after stopping the exercise. He has a history of eczema, seasonal allergic rhinitis. He has a family history of asthma, and he denies resting symptoms or nocturnal awakening. So off exercise, he's completely fine. He uses pre-exercise salbutamol almost every training, which happens basically daily. So he trains daily, and he uses 2 puffs of salbutamol on a daily basis. He's on exam, athletic looking, no distress at rest, normal saturation, normal chest exam. His skin showed mild eczema and the antecubital fossa. He has some pale turbinates, so clear nasal discharge, and some conjunctival congestion. So Yabe in this case used to 2 to 4 puffs per day, just because, as a precaution, because he's exercising daily. He did have a spirometry that showed the normal ratio, normal FEV1 and FVC, but his post-exercise spirometry showed a significant reduction in the FEV1. And this is how we diagnose exercise-induced asthma. Basically, it's a challenge test. We do the test prior to exercise. We let them exercise with a bike or treadmill in a colder air environment, and then we redo the test. If the FEV1 dropped by more than 10%, this is diagnostic of exercise-induced asthma. He has normal X-ray, no hyperinflation, and cardiac schedule was normal. So the preferred approach based on the GINA guideline is to give him, instead of as needed SABA or pre-exercise SABA, we give them low-dose ICS formoterol prior to the exercise, or if they develop symptoms. This way, we can avoid the SABA tachyphylaxis. The regular use over time, if you're overusing SABA, it reduces the response in the bronchoreceptors. But if we use the ICS formoterol over time, it could reduce the prevalence of the exercise-induced asthma, because we're giving on a regular basis an anti-inflammatory that could potentially reduce the intensity and the frequency of the exercise-induced asthma. If you give the SABA pre-exercise, if they elect to use track 2, you give them SABA in addition to different inhaler with low-dose ICS. Unfortunately, they can develop tachyphylaxis, which is basically a blunting of the bronchodilatic response with regular use. And it can give you, unfortunately, because they used to have the SABA and it's always worked, it gives them a false reassurance while the inflammation is still building up, and they might develop an exacerbation without really feeling that symptoms are getting worse, because you can feel the bronchoconstriction, but unfortunately you cannot feel the inflammation. So the teaching point here is daily or near daily pre-exercise SABA is a marker of undertreatment asthma. It's not a management strategy. And regular SABA use causes beta-2 receptors downregulation, and the inhaler becomes less effective exactly when you know mostly need it. So that's where the ICS formoterol could break this cycle. So again, if your patient having just pre-exercise SABA more than 3 times per week, this is a time to consider stepping up, not just be reactive and you just treat whenever the symptoms develop. Now, what's the evidence behind this case? Again, regular frequent use SABA could lead to beta-2 receptor downregulation, which blunts bronchoprotective effect against the exercise challenge. And this has been shown in multiple work that has been reviewed by the GINA Guidelines Committee. The GINA guidance identifies frequent reliever use before exercise as a marker of suboptimal asthma control. And this should warrant the addition of the anti-inflammatory therapy rather than just being in the beta agonist alone. And as needed, ICS formoterol could provide bronchodilation and leads to anti-inflammatory impact even in patients with exercise-induced asthma, and hopefully to reduce the intensity and the frequency of developing the symptoms with exercise. So this is another case. This is a 52-year-old female with a BMI of 38, daily dyspnea, nocturnal cough 3 to 4 times nights per week, activity limitation despite salmeterol fluticasone twice daily, good compliance. She uses SABA 5 to 6 times per day. She has gastroesophageal reflux disease. She's type 2 diabetes, and she has obstructive sleep apnea. She takes the inhalers most of the time. Her inhaler technique assessment reveals critical errors, activating before inhaling and net breath holding. On physical exam, she's obese, dyspneic on minimal exertion, BMI of 38, respiratory of 20, saturation of 93 on room air. She has bilateral wheezing, reduced air entry, both lung bases. She has central obesity, and she had symptoms or signs consistent with the diagnosis or OSA features. So again, the SABA alert here that use a lot of SABA on a daily basis, and it counts to significantly more than 1 to 2 cancers per month, which is more than 3 per year that we were talking about. If you look at her spirometry, she had significant reduction in the FEV1, significant reduction in the FVC, and significant reduction in the ratio. So this patient had moderate to severe obstruction with partial reversibility. Now you can see here that the FVC is significantly reduced as well, and this patient warranted to have full PFT and diffusion capacity. This could be related to her obesity, but you need to make sure by performing a full PFT, because this is a mixed pattern between restrictive and obstructive. The X-ray showed atelectasis, mild hyperinflation, and borderline cardiomegaly. So the gene-preferred tract in this patient is step 4, SMART approach, with a medium to high dose ICS formoterol on a regular basis, in addition to as needed. And the first thing that we need to improve is to fix her inhaler technique. We need to step up in efficacy just by improving an inhaler technique, because the delivery will be better. And we need to address comorbidities, because comorbidities could make asthma control worse, such as allergic rhinitis, gastroesophageal reflux, and obstructive sleep apnea. If you elected to use the track 2, again, you're going to go to medium to high dose ICS LABA in addition to SABA, and you'll be adding medication without fixing the technique. So you have to address the technique, you have to address the comorbidities, and you have to think about how can we deliver more anti-inflammatory without risking the chance of patients overusing the SABA or over-relying on the SABA. And again, the teaching point here is we need every time when patient who comes uncontrolled to confirm the diagnosis, make sure that we're dealing with the asthma. We have to make sure that the inhaler is good technique and compliance. And we need to improve and tell the patient the importance of these things. And we have to address if there's any comorbidities, such as the disease, as I said, or sometimes exposures, if they have pets, if they are smoking, or if they have a work environment that has a significant or constant exposures. Again, this patient, red flags was the saturation was 93%, the daily use of the SABA, and the multiple comorbidities. So basically, this patient needs full structured review and assessment, and to consider all her medical conditions. Now, with regards to the inhaler techniques and the clinical outcomes, this is systemic review reports that almost 50 to 90% of asthmatics and COPD patients commit at least one critical error, irrespective of the device type, age, or disease severity. So حتى لو المريض he's been using it forever, or they know to use, or they claim they know how to use it, you have to observe at least once every few visits that the patient is taking the inhaler in front of you to assess their technique. Incorrect technique is associated with 50% risk of hospitalization, also ER visits, and the need for systemic oral corticosteroids. Structural education also reduces critical errors and incorrect use events, and underscoring technique review as a high-yield, low-cost intervention should be taken in every single visit. Now, I know it's very difficult to do in a busy family business or family clinic because of the frequency of the patient, but try to do it as much as possible, not at least every single visit, but every few visits if you are having a patient frequently seeing in your clinic. So the other case is a 38-year-old female who is working as a healthcare provider as a nurse. She has 6 months history of wheezing, rhinorrhea, and skin rash at work, resolved on days when she is on holidays or during the weekend. Her symptoms usually worse in the procedure room and during her work in the ICU. She uses salbutamol 2 to 3 times per week while at work. No prior respiratory history, exposure to latex gloves and glutaldehyde disinfectant. She has allergy testing done and it's pending. She looks well, appears well, not distressed, satting well. She has faint expiratory release on forced expiration. She had some signs of conjunctival injection and allergic rhinitis, and some urticaria region around her hand and forearms. So the alert in this patient is the frequency usage of SABA during her work days or work hours. So the spirometry was done, showed an FEV1 of 79%, mildly reduced. FVC was normal, ratio was normal, but the post-bronchodilator showed a significant improvement by 15% and more than 210 ml. So that tells you that she has a reversible airflow obstruction. Now, sometimes it's tricky to decide if this is work-related or not. And what we tend to do is we do peak flow meter in the work days and peak flow meter in the off days and see if there is a variability in the peak flow. And if there is a significant variability, this is consistent with occupational exposures. So the decision here was made to start this patient on low-dose ICS formoterol, and the ideal inhaler here because it gives you the systemic relief and the anti-inflammatory protection without being on a daily burden of medication, because if her off days, she doesn't need to be on anything. So the single device ICS formoterol is perfect fit for this patient. She is in step 1 or step 2 in the preferred track. If you use the track 2, she will need to be on SABA PRN in addition to a different inhaler that has ICS. So occupational asthma is potentially curable. We need to identify it early and try to remove the trigger, whether it's latex, disinfectant, that could lead to complete remission of the symptoms if we acted upon it early on within the first 2 years. But if we ignore it, if the patient is using SABA for multiple years, it could become irreversible and we cannot completely cure it. And she needs to be on inhaler lifelong. So the evidence showed that a Cochrane systemic review of 22 studies, almost 1,600 participants, found that removal from the workplace exposure improved both symptoms and lung functions compared with continued exposure. The early cessation of exposure is consistently associated with better long-term outcomes. Delay removal is linked to persistent airflow obstruction despite treatment. And asthma occupational diagnosis early can be cured in high proportion of patients. All right. The next case is a 68-year-old gentleman who is retired. He had a significant smoking history. He quit 5 years ago. He had progressive exertional dyspnea, morning cough, white sputum, and 2 hospitalizations in the past year. He's been labeled before as COPD and prescribed and he's been prescribed LAMA and SABA only because he's been labeled COPD. The thought process was to give him bronchodilator because we don't use inhaled corticosteroids early on COPD patients unless there is a specific criteria. So that's where the rationale that he's only on LAMA and SABA. So he had symptoms worse in winter months, cold weather exposures after an upper respiratory tract. He does, however, have a childhood history of asthma. When he did a FeNO, he has very high FeNO of 52, normal is less than 25, and CBC showed an eosinophilic inflammation. He had barrel chest, a chronic hyperinflated chest or obstructive lung disease, pursed lip breathing, saturation 91% of room air. He had prolonged expiratory phase, bilateral wheezing, reduced breath sounds bilaterally, increased AP diameter of the chest, and he has no clubbing of his fingers. So the SABA alert in here is he's only on SABA and he's labeled or mislabeled, whatever you want to call it, as COPD. If you look at his spirometry, he has a significant reduction in the FEV1 and in the FVC, significant reduction in the ratio, and post-bronchodilation, he had a significant improvement with an FEV1 improved by 17% and more than 200 ml. So this patient has both a criteria for asthma and he has symptoms and criteria for COPD. So these are the patient that we call asthma COPD overlap syndrome, or ACO. And basically they have an element of both. They have the element of the COPD, the exposure and the findings on the imaging and PFTs, and they have the genetic predisposition, the type 2 inflammation, and the family history. So they have both symptoms coexist together, and those are the ACO or the asthma COPD overlap syndrome. So this patient Based on the preferred GINA track, they have to be in step 4 or 5, which is a high-dose ICS formoterol. Smart approach, meaning they use ICS formoterol regularly, daily, in addition to as needed. And you can add on, if they are not improved, a LAMA inhaler on those patients. But the ICS must never be withheld in patients with overlap syndrome, because even if they have a COPD element, you have to treat the asthma component with an anti-inflammatory. And the evidence, again, that there was a pheno, reversibility, and eosinophilia that all led to the diagnosis of the asthma part. If you use track 2, the step 4 or 5, you're going to give ICS on a high dose, LABA, in addition to LAMA. Yeah, I mean, you can add on LAMA in addition to the SABA as PRN. Again, a correct approach, but you need to consider always that you don't want this patient to over-rely on the SABA. Why we keep saying the same thing over and over? لأنه المريض, he knows, whenever I have symptoms, I take the SABA. So they tend to feel more comfortable with the SABA لأنه it gives them the relief they want. So why would I take the other inhaler that just work and that doesn't give me the relief I want? Well, while if I took the SABA, I know just immediately the cough is less, the shortness of breath is less, the wheeze is gone. So they rely on the SABA because it does work and they don't know what happens in the background. So you have to keep in mind that what patients feel is part of the equation. So again, this is just the teaching point of why did we reach to the diagnosis of the AC overlap syndrome. And we need to know the patient is deteriorating because they have no inhaled corticosteroid in their regimen, because they were mislabeled as COPD, where they did have both an element of COPD and asthma. So the evidence says that explicitly GINA stated that ICS must never be withheld in patients with asthma COPD overlap features, even when the COPD predominant is the big picture, due to risk of possible severe exacerbations. Again, the pheno was elevated, the xenophilia was high, and this is an indication that those patients are steroid responsive. And the message here is, even if you have patients who have COPD, I think you have to do pheno and CBC at least every few months to make sure that they don't have any element of an active inflammation in the airways, and to phenotype your patients as well. So not every COPD is a COPD, so you have to always question the diagnosis, look for family history, look for reversibility, etc. So do not take every label as the accurate 100%, because patients change over time, symptoms change over time. So this is a common occurrence. This is a 29 female, gravida 2, para 1, 22 weeks gestation, known asthma since childhood, previously very well controlled on beclomethasone formoterol, 2 puffs twice a day. She got pregnant and she stopped all inhaler because she was concerned about the inhalers and pregnancy. She wants to protect her baby, and she was using only SABA because she knows and she's been told that SABA is safe during pregnancy. She noticed increasing nocturnal cough, dyspnea, and worries that her ICS will increase the harm to her fetus. She is having a pregnant woman examination, 95% room air, heart rate 96. She does have wheezing, and the concern in this patient, or the SABA alert, is she's using significant puffer 4 to 5 times per week, at least after she stopped her ICS. Now, this could be related to stopping her ICS, one possibility. The other possibility that you are aware that in females, when they get pregnant, we're dividing them into 3/3. 1/3 their asthma gets worse, 1/3 their asthma gets better, and 1/3 they stays the same. And there's no way we know which one she will be. So that's part of the pregnancy and the changes happening during pregnancy. So whether that was related to her pregnancy itself or because she stopped the ICS, there is no way to tell. We did spirometry and it showed an FEV1 of 71% reduced. FVC was normal, ratio was reduced, and reversibility showed significant improvement. So this is another clue that she had an active asthma inflammation, and she was reversible with a bronchodilation. So the good approach here is to resume her SMART or MART approach, where is the beclomethasone formoterol. It's same agents as pre-pregnancy. Now, it is not category A, and you rarely find a patient to a medication that's category A in pregnancy. But multiple studies have been shown that ICS in pregnancy is very safe, had a very strong safety records. The unfortunate part is to have the asthma being uncontrolled poses a significant risk on the mother and on the child. Alternatively, you can use daily ICS twice daily in addition to SABA as needed, but again, it has to be in a separate inhaler. So uncontrolled asthma in pregnancy is far more dangerous to the fetus than the inhaled corticosteroids therapy. It raises risk of preeclampsia, preterm birth, low birth weight, and GINA and obstetric guidelines both agree that continuing ICS throughout pregnancy, stopping control therapy out of fear is common and a dangerous pattern that clinicians must proactively counter with reassurance and evidence. So please make sure that pregnant ladies are comfortable using their inhaled corticosteroids without any possible risks, inshallah. طيب. The evidence, again, as I mentioned in the last slide, GINA and major obstetric guidelines recommend continuing the ICS treatment. Inhaled ICS has extensive reassuring safety data in pregnancy registries, supporting its use when initiating or continuing therapy. The unfortunate asthma exacerbations during pregnancy can trigger inappropriate treatment withdrawal associated with adverse perinatal outcomes, reinforcing the importance of maintaining controller therapy. طيب, we have a 31-year-old male software engineer diagnosed with asthma 1 year ago, reports daily breathlessness, frequent gasping episodes, chest tightness despite regular dose ICS formoterol use, confirmed based on his family records. So we checked his dispensing and it was showing he's compliant. He has episodes often occur at his desk during high stress period with rapid shallow breathing and the sensation of not getting enough air. He denies any nocturnal symptoms and he has a history of generalized anxiety disorders. He appears anxious, rapid shallow breathing, normal saturation, respiratory rate of 24, chest showed clear auscultation with no wheezes. Breathing was normal after he gets distracted. He is not using accessory muscles. So the SABA alert here that he is using SABA minimal, which confirmed that the issue is not an under-treatment of asthma, and we need to look for possible other causes. He had beautifully done spirometry, completely normal, no significant reversibility, normal X-ray, and the teaching point here is he needs to continue to be on as needed low-dose ICS formoterol, confirming that asthma is good, but do not step up therapy just based on the symptoms alone. So we have to look for possible causes of increasing in his symptoms that is not proportionate to the typical asthma exacerbation. The symptoms does not fit the description of asthma. In another word, not every dyspnea is asthma related. We have to remember that this patient is an anxious patient and it is related to a stressful conditions, improved when he gets distracted. So all these gives you a clue that this is not the asthma what's causing the symptoms, that it's the anxiety rather than that. And the spirometry, the examination, and the vitals are all proven that asthma is well controlled despite these complaints or symptoms. So the pitfall here is what not to do. So empirically, stepping up his therapy is not the right thing to do. Adding systemic steroids is a not right thing to do because he's going to continue to having these episodes that's related to stress. Escalating therapy without confirming that it's an airway inflammation that's causing the problem, that put the patient in harm, and taking needless medications, which increase real risk of delaying the potential diagnosis in this patient. So the message here, the bottom line, not all breathlessness in asthma in a patient with asthma is related to the asthma, could be something else, and we have to look for clues in the history while we talk to the patients. طيب, this is a 24-year-old female. She had 4 ICU admissions in the last span of 18 months for severe asthma exacerbations. She required intubation twice. She was on high-dose ICS formoterol, in addition to LAMA, in addition to Montelukast. Yet, despite that, she continued to have abrupt, severe attacks with little warnings. This is what we call brittle asthma pattern. So this patient on maximum medical therapy, she had blood eosinophils and total IgE elevated. So this is an indication that she's type 2 asthma. She reports severe attacks, often after upper respiratory tract. So most of her attacks happen after respiratory tract infection. She uses SABA 2 to 3 puffs per week, very considerably low, giving her significant severity of asthma, unlike the previous cases. So her problem here is not the overuse of the SABA. She's currently well between the attacks, not distress. Respiratory rate is perfectly normal. Saturation is perfect at 98%, clear with occasional wheeze, multiple ICU admissions, scars from prior intubations, and she has eczema patches on her flexor surfaces. So again, the SABA was not the problem here. She's not using much despite the severity of her asthma. She did have an FEV1 of 68%, ratio of 64%, and post bronchodilator of 86%. So there is a significant reversibility, despite she is being on maximum medical therapy. And this is a very specific for patients with very significant inflammation or patients who have very severe asthma. She has, alhamdulillah, normal X-ray, no bronchiectasis, and no other etiology or causes of her recurrent exacerbations. So this is a very severe asthma by definition, despite optimum medical therapy. So this patient is the right patient for adding or consideration of biological therapy. This patient needs to be phenotyped. She needs to be referred to a specialized center for consideration of anti-IgE, anti-IL-4/13, or anti-IL-5, based on the availability and the preference of the doctor and the patient. And it showed a significant improvement. It will show an improvement in her symptoms and exacerbation. Now, what you don't want to do is to give the patient frequent steroids or patient to be on chronic steroids. I don't think nowadays it is really allowed for any patient with a severe asthma to be on chronic steroid therapy. So the message here, no patient should be on chronic steroids, systemic I mean, and any patient who have more than twice that he requires systemic steroid, this patient needs to be evaluated for a possible biological therapy. So the evidence, step 5 recommends phenotyping, which is CBC and pure blood eosinophils, pheno, which is does as a breathing test, total IgE on possible RAST, but it's not indicated in all patients, to guide the selection of which therapy is the right for this patient. Biological therapy targeting whether it's IgE or IL-4 or 5 has been shown in randomized trial to substantially reduce severe exacerbation rates and the need for systemic steroids in patients who have severe asthma. And we want to avoid chronic steroids usage because of the well-documented cumulative toxicity. So meaning, if the patient is taking 2 steroids over the last 5 years, this still counts even if he's taking every 5 to 10 years. So every single course of steroids adds on. So cumulatively, if he takes more than 2 grams of steroid, his risk of osteoporosis, adrenal suppression, diabetes, obesity, etc., all goes substantially higher. طيب. The red flag that every clinician must really know is how many canisters should we need the patient is using. So more than 1 canister, more than 3, and more than 12 puffs per day. So more than 3 showed a significant increase in exacerbation risk and mortality, and this patient needs to be really investigated and addressed. If the patient is using more than 12 puffs, this is a very interesting and very concerning, and this patient needs to have an asthma action plan and needs to have adjustment of their inhalers. طيب. This is a 45-year-old male, non-smoking business executive. He had 3 history of progressive dyspnea on exertion, dry, nocturnal cough. PFT showed borderline normal. He has been prescribed SABA, PRN, and beclomethasone twice daily. He's using the salbutamol with minimal relief. He reports air trapping sensation and difficulty fully exhalation. With no smoking history, BMI is normal. His breathlessness, 96% room air, endo-expiratory phase, quiet breathing, end-expiratory wheeze, no clubbing, no cyanosis at rest. So, although the patient is taking an inhaler, taking the SABA, he's still not getting the benefit. And that's one of the things that we always have to ask ourselves. Are we diagnosing the right patient? Are we targeting the pathophysiology of every single patient? So not every asthma has the problem in the bigger airways. What do I mean by that? Most of the inhaler target different or reach to a different deposition in different airways. Some of them do not reach the small airways, which is around less than 2 millimeters of diameter. And that's where the patient that we call them small airway disease. This patient is taking the SABA, but he's not getting the relief that you expected to have on those patients. So if we look at his spirometry, he has reduced FEV1 FVC by 74%. His FEV1 is 80%, and his post-bronchodilator is 88%. But if we look at the small airways, which is the forced expiratory flow at 75% showed a reduction, a significant reduction. It was 48%. So anything less than 65 is abnormal. So this patient is the typical patient of small airway disease. If we want to confirm as well, we can do the impulse oscillometry, but it's not available in most of the places. But it gives us a beautiful illustration of the small airways disease. And this was significantly positive in this patient. So the ideal scenario here is to switch the patient to fine particles, PDP formoterol, which is the basically the Foster inhaler, whether it's the MDI or the Nexthaler, and it has 1 micromole and has a great deposition in the small airways. So it will give him, it will target the pathophysiology of the problem, and it will improve his symptoms significantly. If we use the standard large particle, even if we increase the doses, we're going to get a minimal improvement and getting the side effects from increasing the dose of inhaled corticosteroids. I know I have 2 to 3 minutes left, so I'm going to speed it up. So the evidence here is randomized clinical trial, whether it's the PRISMA or Future, it demonstrated that extra fine beclomethasone formoterol showed significantly greater improvement in the small airways FEF 25-75%, improve in the iOS parameters, and residual volume compared with standard particle. And again, a large real-world study, the REALIZE, which had 8,000 patients, showed patients with uncontrolled asthma, if we switch them to extra fine molecule, it will achieve significantly better asthma control and fewer severe exacerbation compared to the patients who were continued on the standard medication by or adjusting the dose. And Gina also acknowledged that small airway disease is a distinct and often under-recognized phenotype. The clue to it is the FEF if you are doing only spirometry, air trapping if you do the full breathing test, and if you have the access to the oscillometry, it's a great tool to diagnose patients with small airway disease. طيب, this is another case, a 33-year-old female on budesonide formoterol, smart approach, reports good time control, denies any GERD symptoms, negative for sleep study, and she had a FeNO of 48, which basically a clue that her symptoms or asthma is unrecognized or uncontrolled. The symptoms are mainly nocturnal. Breathing test again showed, although the FEV1 is normal, the small airways showed significant reduction, evidenced again in the impulse oscillometry. And the cooler part here is that patient who was on nocturnal symptoms mainly, those patients usually are unique and they might have an element of small airway disease. So this is a clue in the history. If they have mainly nocturnal symptoms, think about small airway disease and try to target the treatment accordingly. So if you switch to extra fine particles that reach to the small airways, you might get the dilation of those areas and hopefully reduce the overnight symptoms. If you're using the standard size, again, you're just increasing the side effects without getting much help. So isolated nocturnal asthma in patients with good daytime control, always think of small airway disease. The evidence, again, small airway disease showed a distinct nocturnal pattern, circadian variation of peripheral airways, and usually it's between 6 a.m. and 4 a.m., precisely when nocturnal symptoms peak. If you use extra fine particles, you will improve the nocturnal variability and reduce the symptoms. The PRISMA study again showed that patients, when they switched, showed significant improvement in their asthma control, reduce exacerbation, and improve in the FEF and the spirometry. This is promised in the last case, 54 ex-smoker, diagnosed as mild COPD, has been on LAMA only, came to the clinic with worsening dyspnea, 2 exacerbations requiring steroids. He has history of childhood wheeze, blood eosinophils of 480, phenol 44. So again, this is similar to the ACO we discussed earlier, where he has element of COPD and element of asthma. Patient showed significant obstruction and also has small airway disease. So the small airway disease is not only in asthma, it has been seen in a significant patient with COPD as well. And that makes it a good option also for patients who have advanced COPD. If they are on LAMA, LABA, ICS, you need to consider having them on extra fine particle if they have FEF of less than 65%. So similar evidence we discussed earlier. And the last case, sorry, I said the last, this is the last case, patient on asthma, Seretide twice a day. She has been compliant, doing great on terms of refilling her prescription. However, despite that, she still have symptoms of uncontrolled asthma. When she showed up to the clinic, she has been not using her inhaler technique properly because she's using multiple, or she's doing multiple mistakes, double puffs, not holding the breath, does not take the breathing in while she is pressing the inhaler. So she has multiple inhaler technique issues. And up to 86% of patients who is on MDI, you have one more than technical error or technique error. So most of the patients do have some error. Sometimes the errors are critical, such as no hand-breath coordination, too fast inhalation speed, or no post-inhalation breath hold. And no matter what you do, if the technique is wrong, they will not get the benefit that you want them to be. Now, there are multiple studies that has been done looking into the clinical errors. This is the red critical, yellow is not that critical, but you need to address those. And these are the best way to address these changes. I'm happy to share these with you later on. So this patient, based on that, you have two approaches. Either you switch to the dry powder inhaler, or you can give her MDI with an aero chamber. She doesn't want to carry two devices. So the decision was to switch her to an exhaler with small particle size, the Foster exhaler. And after 8 weeks, the FEV1 improved from 63% to 84%. FVC improved to 91%, ratio improved, and the asthma control questionnaire showed significant improve. So in this patient, we addressed both the small airway disease, the inhaler error or the MDI techniques error by switching her to a small particle size in a dry powder inhaler. So this is some of the mistakes that happens with the MDI and the beauty of switching to dry powder inhaler, such as Nexthaler. It has been shown that it's a breath actuator, so it does not release unless you prompt the inhalation. It's an extra fine particle. It's flow independent, and it showed same drug, same dose, and no variation despite difference in inhaled peak flow. So عشان بس الوقت, I think I'll conclude with the take home message. So SABA only is no longer preferred by GINA step up therapy. Smart therapy is step 3 to 4 reduce severe exacerbation by 50% comparison to fixed ICS SABA. 3 canisters is the red flag. Before stepping up, confirm the diagnosis, inhaler technique, ensure compliance. Never stop ICS in adults, in pregnancy, or in ACO patients. Withdrawal always have the risk of severe exacerbations. Not all breathlessness in asthma is related to the asthma. True severe asthma needs phenotyping and referral. Small airway disease is real, and it should be considered in any patient with no improvement or FEF, low or nocturnal symptoms, and standard large particle have deposits in the oropharynx and does not reach the small airways. And that's why in some patients we need to change our approach so we can have better results. The device failure is something that you should consider in every single patient, and reviewing the technique is the only way to know. And it's not wrong to switch between devices till you find the right device for the right patient. And finally, Foster exhaler DPI delivers identical estropine particles via a breath-actuated mechanism. No hand-breath combination required. Elderly is perfect fit for those devices, and it can give you the small airway deposition that you are looking for. Thank you, and أعتذر إذا عطلت عليكم.
يعطيك العافية. Thank you so much, Dr. Faris, for the well-constructed take-home message. And the most important part is the way you presented the topic in terms of different clinical case scenarios that touch the reality of our practice and answer, in fact, a lot of questions that well supported by the evidence-based of the GINA guidelines. So because of the time, we have a couple of questions here, Dr. Faris. Of course, you have mentioned elegantly in your presentation, the more the patient uses the SABA, it's associated with the canisters. It's associated with mortality, increased mortality, and it has been evidence in many trials. So the question is here, is SABA overuse primarily a patient adherence problem, or it reflects the physician prescribing behavior, or both? Because we have certain physicians in the primary care, they just keep on prescribing SABA, and the patient get adherent to it because he finds the relief out of the SABA. So where is the problem exactly?
I think the problem is multifactorial. Part of it is us, part of it is the patient, and part of it is just, it is the way it is. Patients have access to the SABA لأنه it's over the counter. It is cheap. The cost حق الكانستر is 12 to 14 riyals. He's been using it all his life. Are we still on? سامعني?
Yes, we can hear.
Oh, perfect. Using it لما يروح البيشنت الطوارئ, when he goes to the ER, they give him SABA. So every indication is SABA is a decent, good medication. So it's our job, not to prescribe SABA alone by any mean, and we keep educating the patient that SABA is not the medication that you need to take it alone. So I think the education part is part of it, but despite all the effort, في factors we cannot control. أنا أخذه يريحني. It's cheap, accessible, but we are working on it. We are we قطعنا شوط كبير, but I think we're still, it is a huge day-to-day problem. By chance أحيانا تكون in the pharmacy buying anything for yourself, شوف المريض يجي يطلب في الفارماسي about 2 or 3 they don't buy 1 canister في الفارماسي ترى SABA, they always do 2 or 3 عشان يحط واحد هنا واحدة. It's a multifactorial. I think part of it is us, part of it is the patient. I think we need to work better on these.
But how you convince Dr. Faris the patient to use the ICS? Because there is a fear of the ICS as a steroids, which is not accepted by most of the patient, and they prefer to use the SABA.
أعتقد you have to the math. If you didn't address it, they will never know. But if you address it with the patient, ترى patient educated these days, ما شاء الله, they read. I think the only way إنهم they keep hearing it from you, from me, from every single one till it becomes the norm.
Absolutely. Well said. Dr. Faris, a question from Dr. Ahmed Dahab. If the patient cannot perform the PFT, is pheno testing can be enough with X-ray and CBC as a replacement?
طبعا الآن it's not into the guidelines yet. However, in the British guidelines, they use it as a surrogate marker for inflammation, keeping in mind that factors that could increase the pheno or reduce the pheno. So smokers, for instance, if they smoke few hours prior to the pheno levels will drop. Sometimes if the patient have allergic rhinitis, will have a high pheno. So pheno sensitivity, specificity is not great, but if they can't do the spirometry, I have the symptoms, pheno will add on to the diagnostic dilemma and we can use it absolutely.
Okay, well said. How important is the management of allergic rhinitis in improving exercise-induced bronchoconstrictions?
So,
Mhm.
طيب, allergic rhinitis usually coexist with asthma, even if the patient has mild intermittent asthma, or if the patient have no clear-cut diagnosis of asthma, they might have an undiagnosed asthma. Once you have genetic predisposition to inflammation, you can always develop it at any stage in different organs. So if the patient has pure allergic rhinitis, it should not impact his chest if he does not have any element of asthma. However, if your nose is blocked and when you exercise, you have a nasal congestion, you will feel that you're dyspneic. But if we do the breathing test, providing that you have no exercise-induced asthma, it will be normal. But you will feel that you're breathless because you're using your mouth solo to breathe.
Absolutely. Dr. Faris, I was very keen personally to answer your question as long as you are here with us. Before escalating therapy, which contribute more to the poor control in your experience? Is it the incorrect inhaler techniques or the poor adherence?
طبعا I cannot
think-
give you a percentage, لكن I believe the adherence is a bigger issue
Mhm.
than the technique. Now, nowadays, the technique, you can see it in your phone. It's a video, it's a relative, so it's easier. But I think the adherence is the bigger issue, I would say.
Mhm. Okay, perfect. So another question is, which biomarkers do you rely on most when selecting biological therapy? Eosinophils, pheno, IgE, or clinical phenotypes?
Okay, so all patients with severe asthma, they have to have eosinophils level, they have to have IgE level, they have to have pheno done, all of them. And do it in a stage where they are not on systemic steroids whenever possible. Once you know the patient's phenotype, you don't need to repeat it. So once you know which patient or what type of inflammation I'm dealing with, you do not need to repeat it. But avoid doing it after steroids use because it will change the results. But all has to be done.
Absolutely. Please, Dr. Faris, there is $1 million questions. If there is only one single recommendation or statement you would like to give it to the primary care physician to improve their competency in managing patients with bronchial asthma, from your own perspective and from your own observations on seeing the referral of patients to you coming from primary care, what will be your take-home message?
No patient should be on SABA alone, no matter what.
Okay, well said. Thank you so much. That was very precise and very smart as well.
الله يعطيكم العافية.
Allah يعطيك العافية. So I think, ladies and gentlemen, I would like, Yani, as we come to the end of this scientific session, I would like to take a moment, in fact, to just summarize, because I was putting some take-home message of mine being in the practice as a primary care physician and would like to deliver it to you as a primary care physician. So my take-home message is treat inflammation, not just the symptoms. And this is a very key message in managing patients with bronchial asthma. So there is an inflammatory component you have to address, not only the symptoms. The second thing is SABA overuse more than 3 canisters per year is a red flag requiring urgent reassessment. And this was said elegantly by Dr. Faris. the trials which demonstrated the mortality, which was increased, in fact, by having more canister use of SABA. The GINA Track 1 ICS formoterol is the preferred strategy across the most asthma severity level, and I think this will be more appropriate for us, to match the practice that we are encountering in primary care. Then I would like to say that always check diagnosis, inhaler techniques, adherence, and comorbidities before stepping up treatment. And this has been emphasized many times by Dr. Faris. So I think this is a golden statement that has to be kept all the time. Personalized asthma management, one size is not fair for all. So we are working through different profile of patients, as was said, almost 12 different cases highlighted by Dr. Faris, demonstrating different profile of patients that need our critical analysis, critical thinking to tailor the management plan based on the patient profile. So there's no one size fits for all patients. The ultimate goal is zero exacerbations and optimal symptoms control and improving the quality of life. It's for us to remember how badly the quality of life of patients with bronchial asthma is affected. So our job is to control asthma, to have a zero exacerbations, and to improve the quality of life. With this, ladies and gentlemen, I would like to, on your behalf, I would like to thank Dr. Faris Al-Hijeri for his wonderful contributions. I really enjoyed the way he presented, and I think it was a remarkable, a new mindset up for us, in order to carry whatever we have discussed today and implement it on tomorrow's encounter with our bronchial asthma patient. So thank you so much, ladies and gentlemen, for being with us here. And I would like to thank the organizing committee and the sponsored by the company, Multaqa Al-Khibrat. Thank you so much for all of you. And on top of all, I would like to thank my society, the Saudi Society for Family and Community Medicine, who give us this wonderful umbrella, scientific umbrella, to have these wonderful sessions on top of it. So thank you so much for all of you. Dr. Abdul
Thank
Habib,
you.
would you like? Thank you so
نعم
much. For
حقيقة دكتور أشرف، استمتعنا مع الدكتور فارس الحجيلي في هذه الأمسية الجميلة العلمية الرائعة الراقية التي زودتنا بمعلومات قيمة جدا ومحدثة جدا جدا. أنا أشكرك دكتور أشرف على حسن الإدارة المعهودة منكم لمثل هذه الندوات العلمية. شكرا لفارسنا في هذه الأمسية دكتور فارس الحجيلي الذي
الله
أمتعنا
يحفظك.
وزودنا بمعلومات حقيقة كلنا استفدنا منها. شكرا للحضور الكريم الذي شاركنا هذه الأمسية. شكرا للشركة التي دعمت هذه الندوة، شركة كيسي. شكرا لملتقى الخبرات بالطبع الذين تعودنا منهم على التنظيم الرائع لمثل هذه المؤتمرات. وقبل الجميع الشكر موصول إلى الجمعية السعودية لطب الأسرة والمجتمع. نلتقي إن شاء الله دوما في ندوات ومؤتمرات علمية ترقى إلى ما يتطلع إليه الحضور الكريم. السلام عليكم ورحمة الله
يعطيكم العافية
وبركاته.
جميعا. شكرا
شكرا
دكتور
جزيلا.
فارس، نلتقي على
شكرا
خير
for
إن شاء
having
الله.
me.
في أمان الله.